This evening, we're hosting a live webinar with 5 experts from University Orthopedics to discuss the Hip Preservation Institute. For those that don't know, University Orthopedics has more than 45 orthopedic specialists, headquartered in East Providence, Rhode Island, with locations throughout the state. All physicians are on the faculty of the Warren Alpert Medical School of Brown University. So I mentioned we have an esteemed panel of experts that are part of a larger network of hip specialists at University Orthopedics. You'll see we have a wide range of specialists who bring a great amount of knowledge to this conversation. Dr. Eric Cohen is an adult reconstruction surgeon specializing in total hip and knee replacements. David Pizzullo is the director of physical therapy at University Orthopedics, also the head physical therapist of the Providence Bruins, the AHL team for the Boston Bruins. Dr. Philip Salko specializes in primary care sports medicine. He's the head team physician at Salve Regina, also on the staff at Brown University. Has some great insight into some of the latest treatments, including stem cell and PRP, that we look forward to discussing. Dr. Jonathan Schiller is a pediatric orthopedic surgeon affiliated at Hasbro Children's Hospital, and Dr. Ron Tabador is the director of the Institute. Dr. Tabador is a sports medicine orthopedic surgeon and the team physician for the University of Rhode Island Rams. Thank you all for being here, and thank you all to the patients who are maybe cooped up at home and looking for a little advice. Most of you are probably here because you do have some sort of hip pain, and we have a great panel of experts to answer these questions. So Dr. Tabador, we'll start with you. Tell us about what the Hip Preservation Institute is.
All right. Well, first off, I hope that everyone who's watching has been staying safe and sound and physically and mentally healthy at home. We know it's a kind of a unique and strange time that we're all trying to adjust to. I just want to let you know that we are still open. We are still seeing patients. We are making ourselves available to people the best we can. Obviously, we would advise everyone to just to use judgment in terms of coming into the office. We're offering telehealth visits as well for those that can't make it. So we just want to, I just want to be able to put that out there. Thank you for having us, and we thank everyone for watching. The Hip Preservation Institute is a center under University Orthopedics that offers a comprehensive multidisciplinary approach to complex hip and pelvic disorders across the spectrum of life. And we have a great group of skilled specialists who offer unique sets of unique skill set that allow the diagnosis and management of these very challenging, sometimes very challenging issues that come across us. The people who are here tonight are basically representatives of a much larger group of specialists that are involved in this process.
And tell us a little bit about your specialty in particular.
So I'm sports medicine trained, but my interest has really been in a lot of hip and pelvic disorders. So I primarily take care of hip impingement, otherwise known as femoral acetabular impingement, athletic pubalgia, which in layman terms is sports hernia, gluteus medius tears, various tears and nerve impingements in the hip and pelvis, hamstring tears. So I try to run the spectrum of what we consider hip preservation.
Great. And I also want to encourage everyone to send any questions you have. We'll do our best to answer those questions. If not, we will post them online later. Dr. Schiller, a pediatric orthopedic surgeon, you deal with a lot of hips. How important is it for you to work with a team like this? Oftentimes you pass on, you might work with a patient up to a certain age and pass them on. And what's it like to work with a team of experts like this?
Well, it's essential, and I'm happy that when Dr. Tabador came to me and Dr. Cohen with this idea and brought Phil with him over to University Orthopedics, and then brought in Dave with the physical therapy, that had been something that was missing from University Orthopedics for years, even when I was a resident. There are some that believe that there is no such thing as primary osteoarthritis, for example, and that arthritis of your hips actually is always related to an underlying childhood problem. I don't necessarily subscribe to that completely, but I do find that a number of children's hip problems then become a problem later on in life when they need to get addressed after the damage has gone on long enough to injure the joint surface itself. And so this collective group philosophy to deal with the hip is quite important, and it allows us to take care of patients in all walks of life, all ages, all types of activity levels.
And Dave, the Providence Bruins are a fun thing to talk about, but your main job is working with hundreds of patients around the area. You've got a team of physical therapists. Talk about the approach you take to patient care and that individualized treatment that you provide.
Well, any patient that comes to University Orthopedics physical therapy would get an individualized evaluation by one of our specialists on the hip preservation team. And this could be a pediatric patient all the way up to a patient that has had a total joint replacement. And we try to, through that assessment, figure out where their physical limitations are, what kinds of difficulty they're having with function, and design an individualized program for that patient.
And Dr. Salko, we'll shift to you. As a primary care sports medicine physician, what skill set do you bring to the table, and a different perspective maybe than some of your colleagues? And we talked about some of these latest treatments that you're able to offer. Can you talk about some of those, please?
Certainly. One of the bigger challenges I have on a daily basis is convincing my patients that I'm not an orthopedic surgeon, even though I'm with an excellent orthopedic group in the state. I'm a family medicine doctor, and so I do my best, as pretty much all of our group does, looking at it from a holistic standpoint and the whole human body, knowing that the hip is not isolated by itself. And then I use that approach to guide my patients and try to get success without having to reach out to my partners in surgery that can and might be necessary. From the other side of the coin, with the specialty training in sports medicine that's primary care, it's related also to further procedures and techniques that are trained in sports medicine for what we do, such as using an ultrasound machine or a fluoroscopy machine to be very, very precise and exact with perhaps putting medication or some of these newer biologics we talk about into the correct area, instead of in the past just kind of hoping for the best and trying to relieve some pain just by spreading the medication around, so to speak. So it's nice working with a group that if there is something that is beyond my knowledge or control, I have someone above me or below me in this picture that I can reach out to immediately and also consult with and bounce back ideas when it comes to surgery versus not surgery.
And one of those colleagues that might be a last resort if some of these things don't work, right below you on our screen, Dr. Cohen, talk about your specialty and what you offer to the Institute.
Yeah, so I'm an adult reconstruction specialist. So what that means is I do direct anterior total hip replacement for these patients that fail to get better with other modalities and have kind of reached the end of the line of treatment. So it is kind of a last resort. What I think is great about the Hip Preservation Institute is that we have everyone here a part of University Orthopedics, and we can collaborate. There's often patients who are kind of in these gray zones, and determining what the best treatment for them can be difficult, but putting all the best minds together to determine what's the best for them is probably the most important. So I work with everyone here, Dr. Tabador, Schiller, Salko, and Pizzullo on this topic for each patient. And we'll always be talking, making phone calls and kind of collaborating to figure out the best results. And then, if ultimately it ends up being a hip replacement, I think the way that I do it from the anterior approach, which is from the front of the hip, offers a lot of advantages for especially some of these young active patients. It's really minimally invasive. I can use fluoroscopy to dictate where the cup position and to really restore the femoral offset and length appropriately, rather than just guessing and coming out of the operating room. So it really allows a quicker recovery and a precise surgery for these patients.
Dr. Tabador, back to you. A lot of folks are stuck at home right now, have some pain going on in their hips, which is why they're watching, or one hip. What are the things they should be looking for, and what are some of maybe the signs that it's time to talk to a professional?
Yeah, so first off, one thing I forgot to mention earlier is congratulating Dr. Cohen on the birth of his daughter a couple days ago, Zelda. So it's very, very exciting. I just wanted to throw that out there. So in terms of when patients should come, so let me just back up a little bit and talk about what are some of the challenges of managing and diagnosing some hip and pelvic disorders. The problem is that a lot of these issues can masquerade or mimic as low back pain, as gynecologic issues, urologic issues, general surgical issues. They can present as knee pain. So the biggest challenge is trying to understand where the true source of the pain is. So it's even difficult for the patients to even know that and to even know exactly where they need to go and who they should see. I think that broadly speaking, if a patient is at home and they're at a point where their quality of life is compromised, they have dysfunction, whatever pain that they have is preoccupying their mind most of the day. It's preventing them from sleeping. It's altering their lifestyle. That's definitely an indication that they need to reach out to a specialist and have it evaluated.
Dr. Schiller, a little bit different when you're dealing with children and parents. So this message would be to the parents. What should parents look for when it comes to their kids? Is it the way they're feeling, the way they're walking? What are some of the signs that attention might be needed?
So it depends on the pathology. So when we look at kids in general, there are, typically three major issues of hip pathology that will end up causing big problems that are non-sports related. So that would be hip dysplasia or dislocations as babies, what we call Perthes disease, which is a type of avascular necrosis, which is a lack of blood flow to the femoral head, causes collapse. And then the other one would be a slipped epiphysis. Those are the big three. And that's when the growth plate slides off the top of the femoral head as they're maturing. But the rest of that is all, hip pain from athletic injuries, falls, trauma, whatever. So obviously those should be addressed if it's bad enough, as Dr. Tabador had said, is if it's really causing so much discomfort in the older kid or even a toddler that's waddling around or limping or whatever, won't bear weight more commonly, then they should come in. With the chronic issues that we talk about, like dislocations or dysplasia, most of those are babies, and those will be sent in by the pediatrician. So the parents don't really have to think too much about it. If they're learning how to walk and they see a leg that looks different lengthwise, a discrepancy, that may be a key in for something going on with the hip, but it could be related to something else. The other two, the Perthes, which is the lack of blood flow, that's something we typically see around age 4 to 10, sometimes as young as 2, as old as 12 or so. And that they'll see the kid will look like they're kind of dipping to the side, what we call a lurch. They'll also have some pain and a lack of motion. The skiffy is pure pain, and they will be turning their foot out to the side. But those children tend to be a lot heavier. Tend to be overweight. So those three main things, there's certain telltale signs that we know that will bring them to the ER, or their pediatrician will automatically refer them to our office. The rest of it, as Dr. Tabador said, if it's killing you enough, you got to come in and have it evaluated, or at least do a telehealth visit or telephone telemedicine visit to at least sort of help kind of figure out what you should do.
And Dave, shifting over to you, you see a lot of sports injuries that come in. Are there hockey-specific hip injuries that you see? And then how often are patients able to see you with a program and get better without having more treatment? I think a lot of people could be afraid of going to see a doctor because they don't want to hear the news. How many success stories do you have of folks that come in and do the proper PT and get going on their way?
I think there's quite a few success stories. There's a lot of different pathologies that are related to the hip. Many of them can be addressed in physical therapy, and people can resume their normal lifestyle. There are situations where people don't improve, but that's why we have such a great team, is that we can try physical therapy. If they don't have success, we can have them see Dr. Salco or Dr. Tabador or Dr. Schiller, or even eventually Dr. Cohen, if the progression of the pathology cannot be corrected with physical therapy.
And Dr. Salko, the labral tear is a big term that comes up when we talk about the hip. And there's a lot of, I guess, misconception about, oh, this is what it is, and maybe it isn't. But the percentages are very high for people that have the tear, but it might not be their issue. Can you discuss that a little bit?
Yeah, so there's a couple of different dependent factors, speaking about the two doctors that do these surgeries a lot, where it depends on the age. That's one key factor. And we do a lot of different studies, such as an MRI, that may actually show something like a labral tear. And it may actually be in a hip where that's not even the symptom at all, and they're not even having any discomfort from it whatsoever. And it doesn't necessarily mean when you see labral tear on the MRI, you need surgery. But it also can be something that can be corrected properly, and when properly dealt with, perhaps after physical therapy is perhaps not successful and there's continued pain, we want to also be very certain on that truly is the source of pain. So one thing that I can offer is being very precise with perhaps a diagnostic injection with something like lidocaine. That I just did one today, actually, which was thankfully very, very helpful for that boy. He got up out of the table, and he did a couple of motions with his hip that normally would just kill it, and thankfully it didn't hurt him at all. And so that's information. So it's really important, and I know the other two docs that do these surgeries can talk a lot more on it, but it's really important to, once again, like Dr. Tabiter said in the very beginning, know what truly is giving you the pain, because it could be mimicking a bulging disc in your spine, possibly. That was the source the whole time. And when we identify something on an MRI, it doesn't necessarily mean we need to act upon it with surgery or with anything else in between.
And Dr. Cohen, your approach, you've got a very unique, I think, to this area, to this region of the country, of a way that you perform surgery. Can you talk about that technique?
Yeah, I talked a little bit about it earlier, but basically it's from the front of the hip, and it's going in between two of the major muscles of the hip, and so you're not cutting any of the major muscles. It's actually a natural nerve plane, so you're not going through the nerves, and as a result, you're really just kind of doing a replacement kind of in situ without having to disrupt a lot of structures, and that really results in less pain and a quicker recovery, which I think is great for these patients that end up needing it. I'll just echo what Dr. Salko was already saying about labral tears, and really trying to figure out, is that the cause of your pain? Oftentimes it is, and I think this multidisciplinary team here can determine what treatment is best for you. Other times it's not, and it could just be an MRI finding. And so I think having a team of experts looking at it from all angles is really important, so you really get the best care.
Great. And a question just came in, Dr. Tabor. We'll circle back with you. Does physical therapy help an arthritic hip?
Yeah, I actually think that Dr. Cohen would probably be best to answer that question, but I do want to just circle back on a comment with the labral tears, and I know that Dr. Schiller would probably echo this as well because he sees the same thing in his clinic. 67% of the walking population are going to have labral tears at any age, and our job as clinicians, when these patients present to our office with an MRI that shows a labral tear, is to determine, is that labral tear clinically relevant, or is it just an incidental finding? And I can tell you just from my experience, a majority of the tears that walk into my office are just incidental findings. And that the pain that these patients are really presenting with are other structures around the hip and pelvis. People need to understand that the hip and pelvis is a complex network of nerves, ligaments, muscles, tendons, bony structures, all that can create pain. And so we have to basically determine where the true nature of the pain is. But it's important for people to understand that it's actually a lot rarer than people think. The labrum's kind of become a very in vogue thing in terms of a diagnosis, but very rarely is it actually the cause of the problem.
Dr. Cohen, would you like to take that question on arthritis and physical therapy?
Yeah, absolutely. So physical therapy can definitely help arthritis and your arthritis pains. That being said, hip arthritis is really a spectrum from mild, moderate to severe. So there are some patients that maybe won't benefit from physical therapy because their hip is so far gone or collapsed, and they're really having difficulty walking. They can barely ambulate. You can't even move their hip without significant pain. And so those patients, maybe not, but I would say the majority of patients do. We know that exercise helps arthritic joints, low impact exercises, and physical therapy. And so that's really kind of the first line treatment for most patients with the disease. But again, it's really a spectrum, and kind of having a specialist take a look at you and take a look at your x-rays, and kind of putting the whole picture together is probably the most important thing starting off.
Dave, do you want to add anything on that as it relates to physical therapy?
Sure. I think physical therapy is not going to certainly cure arthritis, but when you look at the natural history of osteoarthritis of a joint, you start to lose mobility, you start to lose strength of the muscles around that joint, and that's where physical therapy can be beneficial. We can address mobility and strength issues and improve function. Are we going to change how your x-ray looks? Certainly not, but we certainly can have a positive impact on the quality of life. I would agree with Dr. Cohen. There are some points where the joint is too involved, and that strengthening the muscles and mobilizing the soft tissue around the joint do not provide relief. And so that sometimes a surgical intervention like an anterior total hip is necessary.
Dr. Salko, how do you know when it might be arthritis? What are the telltale signs that's the case, and it might be something that is chronic and you have to deal with it? It won't get better on its own.
Yeah, there's one very typical presentation is what we call startup pain. And that's classic when you've been sitting in a chair for a while and you're doing okay, and you go to get up and you're like, oh, what is this pain that I feel deep in my groin or in the outer part of my hip? And you get going for a little while and it kind of goes away. And I get multiple reports of, hey, if I keep moving, it's not so bad. But man, after that movie, I got up and I had a lot of pain. And that's one of the ones I like the most that stands out.
We have a knee question that came in. At what point should you see a doctor regarding severe knee pain? And a lot of you have expertise in a lot of different areas, so that's kind of off topic a little bit, but we're trying to answer all the questions that come in. Dr. Tabador, you do see knees as well. Mm-hmm. When's it time to see a doctor?
Yeah, I think it kind of goes back to what I was speaking about earlier in terms of function, quality of life, what you're able to do on a daily basis, and how compromised you are. So, if your knee is swelling up, if it's locking up, if you're not able to engage in the activities you're typically used to doing on a regular basis, and you find that your life is really compromised, I think these are basically signs that you need to see someone. And what's also important is to know that knee pain may actually be coming from your hip. A lot of patients do present with knee pain as an initial symptom of hip pathology.
I'd like to add on that as well, if that's okay. For all the athletes out there in high school, college, whatever, a good athletic trainer told me when he comes up to his athlete and they're on the sidelines and it's hard to tell whether or not they can go back into the game or they have something terrible happening right then and there. He usually says, "Are you hurt or are you hurting?" And I like that phrase because it lands to the athlete of like, no, this is scaring me. I don't know what this is and it hurts. Versus, it's muscle soreness maybe. It's at least it's a trigger to lead you in the right direction. And number two is that we aren't the only ones out there that want to see and help knee pain or hip pain. We're here to help, and there's a whole group of surgeons, doctors, and everything else in between, such as your primary care doctor, that is available. At least, thankfully with telehealth right now, I know we're getting into a whole other subject there, but if you're scared, at least reach out.
I mean, I think it's important. I want to add in, knee pain is commonly referred pain that I see in the pediatric population. In fact, one of the problems I was talking about, a skiffy or slipped epiphysis, that is almost always what they come in with, is thigh or knee pain. If they don't come in with complaining of hip pain because it's referred. So that's a very good point that, don't sleep on your knee just because you think it's a knee thing. It might actually be your hip. The other thing I want to touch on quickly is I feel very strongly that all of us in this group and our partners at University of Orthopedics, while most of us are surgeons, we have our primary care people who are dealing with our patients as well. We would love to get everybody better without having to do any surgery, but inevitably it almost, we lose sometimes, and that all our non-operative modalities will fail, and that brings you to surgery. And the key for what I'm trying to say is that regarding your labral tear point, people come in with labral tears, they're usually not complaining of the pain from their labral tear. They're usually symptomatic from their abductors being sore, or their hip flexor is sore, or they're sore anywhere else. And so we treat symptoms a lot of the time, which is why I find therapy is helpful. But when all of our non-operative therapies have failed, then we have to do something surgical. And it's amazing. Dr. Tabor will tell you, Dr. Cohen will tell you, even Dr. Salko will tell you. We've looked at x-rays where the picture is the same side to side. Right and left look identical, but the patient's only complaining about one side. So, we treat the patient rather than the MRI that says a labral tear or an x-ray that looks horribly arthritic. It's the patient's symptoms that inevitably are going to drive us to our treatment decisions.
We had a question come in from a viewer. They asked about how important it is to be at a moderate weight before surgery, and that they may have gotten some information to hold off until they lost weight before they had hip surgery. Who'd like to answer that question?
I'll go ahead, Dr. Cohen. I'll let you.
Yeah, so certainly we know that weight plays a role in surgical risk. So if you're having surgery, if you're overweight, or typically we look at body mass index, which is BMI, over 40, at least for a hip replacement, and I think this is true mostly for most other hip surgeries, that you have an increased risk of infection and complications. That being said, kind of to echo what Dr. Schiller is saying, I think looking at the whole individual is most important. A lot of times what we'll do is we'll counsel and we'll talk about these risks, and then try to work with you on a diet and exercise program, often some pre-rehabilitation with Dave Pizzullo and his team can be really important to preparing yourself for surgery, whether it's a hip replacement, a hip scope, or any other type of surgery. And so I think doing those things to kind of optimize your health is probably the most important thing. Again, weight is just a number, and we're looking at the whole person. And so if there's ways we can get you healthier, maybe you don't need that surgery, but if you do, we want to at least optimize you so you don't have as high a risk as you would. That being said, everything is kind of patient specific, and so I think having a consultation and having that discussion is important. It's important and completely reasonable to get second opinions on your hip issues, and I think that's what's nice about this group here, is that we basically are always getting second opinions by talking to each other, and saying, hey, what would you do for this patient? What do you think is best? And so I think you're getting 1, 2, 3, 4, 5 opinions pretty quickly, rather than trying to navigate the healthcare system for those opinions.
We're also sensitive to the fact that patients who are overweight because they're in pain, and sometimes it's hard to lose weight just by diet alone, and they can't exercise because they're in pain. So we're very sensitive to that, and we will do everything we can to work with you to really help you get past that, and help treat you the best we can, understanding your situation.
Absolutely.
There was a follow-up question. I think you answered it somewhat, but Dr. Salko, for someone who wants to make sure all the bases are covered to getting to the bottom of that hip pain, what sort of, appointment would that look like to get looked at?
Yeah, that's a good question. So oftentimes what I like to do is get an excellent story from my patients. So getting a quality amount of information and letting them tell their story, when it began, how long have they been dealing with it, what have they tried so far on their own. I'd say getting a good, healthy history from a patient is one of the most important parts about what I do, and trying to have that conversation, looking at them, seeing them walk, seeing them move, seeing how they're managing it, and then followed up by a good physical exam, really honing in on what's going on, where is the pain, can we touch on the pain. I do also point of care ultrasound, so we may look at it together in the office and say, does it hurt when I touch that? Yeah, that's it right there. Or we may not find that. So whatever we find in the physical exam, that's the second most important part. The other parts in terms of x-rays and MRIs, sure, they're important, but without having the context of what that patient, their age and everything else in between, they don't hold any weight at all. You need to know what's going on in that human body and how they're suffering. Maybe they're not going out on their boat this summer because they're having trouble actually standing on it because of their balance problems unrelated to their hip altogether. Or maybe they're afraid to try out for the team because their shins or their hip is bothering them so much that they're not running as much as they want to anymore. So those factors are really important to get that. But thankfully, at all of our facilities, we have right there, they come in, we talk to them, we order the appropriate study, ultrasound, x-rays right there on site. And then if necessary, more imaging like an MRI, which we also have available and can order when we find it's necessary. So in a way, we'd like to say, you're going to come in, maybe you'll see me, and eventually you might end up seeing any of the other providers you're looking at right now. And perhaps any of them are going to be the one to truly fix it and correct it to the best as possible. And it might, maybe not, maybe just me, a simple conversation, and that's it. I love working hand in hand with Dave Pizzullo because I have questions that I get to bounce back, and when they come back and I get feedback from how they tolerated and or did physical therapy, that gives me a ton of information. And I get lucky every now and then. I help my patient by breaking their pain cycle by perhaps giving a single cortisone injection into their hip, and then having them once again go back with Dave Pizzullo or any of the physical therapists, and it lights it's like lighting the fire, and they get inspired, they lose weight, they work on the exercises that are the proper exercises, and they move on with life.
Dave, let's shift over to you. Talk about the physical therapy at University of Orthopedics a little bit, where you do have staff members who focus on certain areas. Might be back, might be hip, but not everyone is covering everything, I think, which makes your staff members a lot better at what they do.
Yeah, the physical therapists at University of Orthopedics all specialize in orthopedic rehabilitation. Now, there are some subspecialties within orthopedic rehabilitation: shoulder, knee. Tonight we're talking about hip, but I'm not the only physical therapist. We have a team of physical therapists that have advanced training in hip rehab. And so, and they're located at multiple sites. So any patient that's listening that wants to go to physical therapy can see someone who's specially trained in hip at just about any of our locations in Rhode Island.
Dr. Tabador, we had another question come in. You covered a little bit about the back pain could be coming from the hip. The question was kind of the reverse. Can hip pain lead to back pain?
So there's a couple ways to answer that. Hip pain can lead to back pain, and hip pain could be coming from the back. So in terms of the hip pain causing back pain, if your hip mechanics are off because you have either arthritis or you have hip impingement or some muscular tear that's causing you to walk in an altered way, that altered mechanic is going to basically put stress on the back and basically cause low back pain, muscular aches, spasms. So in that regard, the hip itself can cause low back pain just by altering the way you walk and changing your mechanics. However, if you have a nerve impingement from a disc herniation at a certain level in your spine, that could cause hip pain. And so the hip pain is actually not necessarily primarily hip-based, but really from the back.
Great. Another question just came in, and Dr. Salko, I know you love to analyze runners. We've talked about running programs. A runner here asks, what should they be doing to keep their hips pain-free, on and off hip issues since they began running a few years ago?
Yeah, looking at your whole body comprehensively, like, so run, by all means run and enjoy it. Maybe mix it up every now and then and do a yoga class or a Pilates class or some weights at home, or if you ever get back to a gym, in the gym. And there's all kinds of creative ways to keep your pelvis stable and your pelvis strong. So then when you get to finish your 1 mile or finish your 26 miles, you're staying stable through the pelvis and the hips. And don't forget to stretch. And I know this is silly, but I still talk about it a lot because I get questions a lot, is don't bounce when you stretch. Make sure you stretch for a good 45 seconds to a minute per individual stretch. And I know Dave Pizzullo, I'm sure we can talk about that for another hour on top of that, but make sure you're not just doing cardio as well as strengthening around your hip and pelvis and core, as well as stretching. So all three of those are I like to say, are almost as equally as important to each other to maintain balance. So you can enjoy running.
Great. We got a follow-up as you were answering that. How do you all feel about treadmills? Dr. Tabador, how do you feel about treadmills? You've done some Ironman in your day. I'm sure you had to be on a treadmill.
Yeah, I think, look, so first of all, there's all different kinds of treadmills now of all different qualities. Second, I think the way you run on a treadmill is going to probably be a little bit different than the way you run when you're outdoors. I mean, your stride's going to be a bit different. You're going to open yourself up a little bit more when you're out on the roads, or if you're on trails. You may be a little bit closed in, or your stride may shorten on the treadmill. But it's unique to everyone. I mean, someone who's trained on a treadmill and is used to a treadmill are probably going to do better on a treadmill, rather than someone who is used to being an outdoor runner, runs on a treadmill every so often. I think it's good if you don't have access to outdoors and you want to kind of stay in shape and continue to run. So the treadmill is good in that regard. But I do think your mechanics are going to be a little bit altered when you're running on a treadmill versus being outdoors. I think Dr. Salco can probably speak more to that as well.
Yeah, it's a challenge that I run into. So I do video running gait analysis, and to see the repetitive motion of the foot landing, the hip stabilizing, and even through the shoulders and the pelvis, the challenge is almost always patients tell me, I'm educated by my patients all the time, and they tell me it doesn't feel right, or I don't typically run on a treadmill, but it's a wonderful, healthy means to an end to stay at a healthy weight and maintain cardiovascular health. But at the same time, I'm able to video them on the treadmill and see the repetitive motion and at least catch some very basic edits to their running technique that we can then focus on and possibly adjust just enough to get corrected without doing anything else except making some minor adjustments to the running technique.
Dr. Schiller, treadmills and kids, what are your thoughts on that? I'd imagine a lot of families this year have, my house included, given the kids a little leeway on the treadmill because they couldn't go outside.
Well, I mean, for the older children, I would say they're not children, adolescents and teenagers, I think those are great. I mean, as Dr. Salco said, Dr. Tabador said, for them to run on that, I think it's wonderful. It's like a stationary bike, a Peloton, all that. Everybody loves those. Okay. The younger kids, the little ones, I think it's just another way to come see me in the office for a broken bone. So I would probably be very careful about putting children on a treadmill. But if they want to and they're capable, low speeds, I think it's reasonable. Certainly walking on a day where they don't want to go outdoors and it's raining, they can be indoors, walking on a treadmill. One thing I do want to stress, Dr. Salco had mentioned it, but I really think it's a great idea to cross-train. So people that run 4 or 5 days a week, I strongly encourage breaking that up with running, biking, if you get to a gym, doing the elliptical, a rowing machine, a Versa climber, swimming, anything to mix it up, use different types of muscle groups. Because what I find is regardless of whether it's running, the bike, just the treadmill, whatever, if you do the same thing over and over repetitively, you're going to end up with overuse injuries. And that'll be another way to end up in our office.
Any other thoughts on tips on training. A lot of you are very active, sports medicine. The gyms have been shut down. It's a different time, but anything else? Dave, boy, the ice got melted early this year. So any advice for some of the parents and athletes out there?
Well, I mean, my kids, Dave, go ahead. I'm sorry about that.
Yeah, no problem. Yeah, I think it is challenging to be able to get an adequate workout, especially as an athlete. For our hockey athletes, it's very, very challenging because they don't have access to ice right now, but they certainly can work on some dry land training, working on aerobic fitness and strength development, and we'll be open soon and they'll be able to get back on the ice.
Sticking with the sports for a minute, Dr. Tabador, you were with University of Rhode Island as they were down in New York getting ready for the A10, making a great run. What was that like for you to be in the midst of that with the team, and they had to turn around and head home, and that was really the beginning of what we're in now?
Yeah, I was down there with them, and yeah, it was really disappointing. I mean, obviously there's a major health concern and pandemic going on, so there's no question it's a no-brainer. It takes priority. But you have seniors who are walking away from their college athletic career, not having the opportunity to really kind of reach what they feel the potential is. And so there's a kind of a sense of disappointment for a lot of people who put a lot of work into their winter season. At least the athletes in college that are spring athletes, they're going to get that season back. So that's going to count as a redshirt season. But for the winter athletes that have gotten that far into the season, that end up not able to be able to compete at a regional or national level, I think it was really hard. It was really hard. But I got to tell you, all the athletes handled it with a tremendous amount of dignity and respect. They understood the bigger picture and what was going on. So they really handled it very well.
Dr. Salko, also a big sports fan. You're on the sidelines at Salve and at Brown. I just heard the news that the New England Collegiate Baseball League has decided to cancel the season in Newport, so the Gulls won't have a season. What's your feeling like, and what are your thoughts on returning to action?
I'm heartbroken for all my student athletes and students at Salve and Brown University. They just offer me such a wonderful perspective of such a strong desire to be active and put themselves at a higher level in terms of their sport and their education. And I'm very hopeful that we're going to get through this on the other side, and it's going to be a lot sooner than people think, but I have no idea when that is. However, it was tough to see the athletes have to head on out, and they also, like Dr. Tabador said, took it with seeing the bigger picture. And so, no one, went out kicking and screaming or anything like that. They understood what was important here, and I'm looking forward to seeing them again soon.
And anyone else want to comment on that? Just want to make sure I get everyone in. We have a question that just came in about doing hot yoga, and it's been great for this person for their arthritic hip. Right now, unable to do that. Any alternatives, Dr. Cohen, that you can think of to maybe take the place of that?
Yeah, I think it's with the yoga studios being closed, I think having hot yoga to find a replacement for that's going to be difficult. But I think still staying active and doing yoga has a lot of benefits. And so I hear from a lot of my patients that yoga is just great for their hip pain, their hip and knee pain, and there's some of my happiest patients that do yoga. So I would say keep doing it, and hopefully soon you'll be able to get back to hot yoga, but stay in shape in the meantime. And that's probably the toughest thing I think all of us are dealing with being at home is getting the motivation to get out and do things. And so I would just say keep doing it.
Hey, Pete, I'd like to kind of circle back to make sure people understand kind of what the concept of hip preservation actually is. When we actually talk about hip preservation, and I'd like to hear comments from the rest of the panel on this as well. Historically, the birth of hip preservation was really an attempt to build a field that can reduce, not necessarily halt, but reduce the progression of arthritis, or people progressing to end-stage arthritis that's going to require a total hip replacement. And that's where procedures like hip arthroscopy really kind of came in. I kind of look at hip preservation now, especially with this group of specialists here, as preserving the function of the hip and the pelvis, not just the joint, but the muscles and the tendons, the motion, the mechanics. So I think there's a broader sense and idea of preservation when we talk about this kind of Hip Preservation Institute.
Sure. Who else would like to? Dr. Schiller, would you like to follow up on that?
Yeah, no, I agree. I mean, when the reason hip preservation sort of was born is that nobody wanted to do hip replacements earlier than really before age 65. And then it was 60. And now you're going lower and lower. And that was because the technology really wasn't that great, that the life expectancy of a new hip was going to last that long. And so because what we're doing now is better than what we were doing before, and the implants we're using are better than what we were using 10, 15, 20 years ago, they're lasting longer. And so, as Dr. Tabador said, our job amongst the five of us here and our colleagues that do similar things is to really keep the hip functioning as best we can until it falls apart, basically, right? And so if the end stage falling apart is a head that collapsed from osteonecrosis as a child, and it's the end stage is at age 18, then that's where it is. If it's an osteoarthritic hip because it's a manual laborer who just has beat it up forever and that end stage is 45, well, then that's where it is. We just try to get them there as let's say, as slow as we can so they can keep the life of that hip, but to keep them comfortable so that they can function with that hip. And, from Dr. Tabador and myself doing arthroscopy to osteotomies and cutting the bone when you're a kid to angle it and give the alignment a better chance to maintain its life. Dr. Salco helping with us doing that, and Dave Pizzula doing that with therapy. And then finally to Dr. Cohen, that's really what we do. It's the complete hip. That's what we're trying to keep. And so, we don't stick to hard numbers. We stick to the function of the hip. And so we'll do what we need to do to get patients back to where they want to be. Sometimes we have to do that younger. Sometimes it's older. That's what we're here to do, and that's our function.
Yeah.
We'll go around the. Oh, I was going to say we'll go around the horn. So Dr. Salco, go ahead.
Oh, sure. I'll go next. Something that I do specifically that I want to touch upon that I briefly mentioned at the very beginning is all these different options that people will Google and look up and say, hey, I want that. And specifically what we call this category called Ortho Biologics. And so there's a lot of different things out there that people are afraid of and also completely believe in, and the data can be all over the place. So just briefly, I'd like to summarize them. And so you can step away. If you have further questions, of course, we can answer them later. So number one, cortisone. It's not necessarily good for your body. When done sparingly and the right way, it could do a very good job at breaking the pain cycle for a patient. Like Dr. Schiller said, getting you to where you want to be or need to be. Then there's all these other options that aren't necessarily completely covered by insurance. There's all kinds of different ways and techniques they were developed. And there's all kinds of research that is positive and not necessarily so positive. One big one out there is called PRP, also known as platelet-rich plasma. This is your own blood, and we take it and we concentrate it so it's the best healing factors in your blood, and then we put it back into the problem areas, such as your hip with your labral tear, or your gluteus tear, or your proximal hamstring tear, that may not necessarily be recommended to have surgery on, but it's still giving you some discomfort. And there is actually surprisingly good data behind this, but there's also mixed data too, that if you just simply inject it into an old arthritic hip, it's not going to give you a new hip all of a sudden. It's not going to take those bone spurs and make them dissolve away. And so it's important to choose this therapy when it's done properly. And for the most part, when I do these procedures, it's because patients have already had a discussion with maybe one or two other doctors, surgeons, that are trying to say, hey, you know, Dr. Cohen, you don't want me yet. You don't want me to do this yet. And I'm here for you when it's helpful, and thankfully we have all these doctors that we work with that I get to go, hey, I'm not sure, maybe we should step into surgery or not, and then bounce back to me. Another one that's out there, unfortunately PRP for the most part is not covered by insurance. There's a very wide range of costs, and I just would advise everybody out there to have a basic discussion with your regular doctor or with any of the great doctors and physical therapists at University of Orthopedics, and they can give you some basic guidance. Unfortunately, there are some people out there in many other states that charge just exorbitant amount of money for it, and it's just not right. Another category that's getting a lot of pickup is cells derived from an elective C-section, such as the placenta after the fact. A woman has a natural, lovely childbirth and signs up ahead of time and says, hey, go ahead, you can have that, and try to do some research on it. And these are being sold across the United States, and there are some very positive cases. The data on that is quite early and quite mixed. And so this is not the panacea, one stop, you're going to get this lovely injection, it's going to fix everything. But at the same time, I really have to say, with my humble opinion, I see benefits of it when chosen the right way and on the right patient. And then there's many other things. Well, I didn't even mention the stem cells, because a lot of people think that what I just mentioned actually was stem cells, and that's not. The only way you can truly get stem cells is by obtaining it through the bone in the pelvis and then cleaning it, concentrating it, and then once again re-injecting it into the problem area, such as your hip. And they are not necessarily doing it properly at many locations where they say they are. So just a little background research is really important. And I'll leave that subject alone for now, because I'm sure we can have a whole other discussion on that.
Very well said. We'll continue to go around the horn. Dave, we were finishing up on preservation and your role in the hip preservation. Tell us about that, please.
Yeah. I would agree with Dr. Tabador. You know, hip preservation is relatively new in the world of orthopedics, and the beauty of physical therapy is we're not heavily dependent on imaging, so we don't order MRIs or X-rays, but we look at function. We've always looked at function. How is a patient functioning? Where is their dysfunction? We'll look at their physical limitations, mobility, flexibility, and strength, try to address those so that we can improve their function. So we're not trying to fix a labral tear or correct impingement or reverse arthritis. We're always been functional based. So that's the beauty of physical therapy when it comes to this hip preservation.
And Dr. Cohen, as a reconstruction surgeon, you know, your role sometimes they say is the last resort, but times have really changed. You've come into this field at a really exciting time. Talk about your role and what preservation means to you.
Yeah, so I think it's, you know, working with these guys to find, you know, the best treatment for your hip. It's really great, you know, to work with Dr. Tabador and Schiller. Oftentimes we'll even do cases together. And I think it's really important because it broadens our understanding of the hip as well, working together, which I think is awesome on these cases. And then Dr. Schiller is working with a lot of pediatric patients who have some really tough hip problems. Certainly down the road, they may need a hip replacement. The great work that he does may be able to hold them off for a hip replacement until they're in their 50s or 60s, maybe sometimes later. But the important thing is that he understands that the next step may be a hip replacement down the road. And so, you know, he'll take that into consideration when he does the surgery. So that's something as simple as removing the hardware, or placing the hardware in places that will make the next step, a hip replacement, way, way, way down the road earlier. Some of the toughest, most complex cases I do are actually patients who've had prior hip surgery and have implants left in for 20, 30 years where the bone overgrows, and then retrieving those implants can be very difficult. Makes it a more complicated surgery. It makes a longer recovery for the patient. And so really having a comprehensive team that understands that, they're going to do a great job with the initial surgery, but know in the future you may need additional surgery and take the right steps for you, which I don't think anyone ever thinks about going into it, but our team here is thinking about that. So I think working in collaboration with them has just been great as far as that goes.
Yeah, Pete, I think it's also important to note that hip preservation doesn't end at a total hip. Hip preservation continues beyond a total hip replacement. So the patient that has a tendon that's rubbing against the implants of a total hip, rather than replacing the whole implant and taking it out and putting in new parts, you can go in with a scope and release some of the tissues. Patients who have had total hips can have gluteus medius tears, and that can really lead to a lot of dysfunction that can be managed and handled either therapeutically through injections or with surgical intervention. People with total hips can also have hamstring tears, or they can have nerve impingements and other various issues. So I think it's important to know that you're not done once you have a total hip. Hip preservation can still be available to you.
Yeah, I think that's a great point that Dr. Tabiter brought up, and it's something we're actually looking at University of Orthopedics. We're collaborating together on these patients because we think that some of the things that we're doing here may be better than what is currently out there. It certainly is better. Our patients are doing great from some of these tendon releases and other minimally invasive procedures rather than a re-revision type of surgery. So these can be great options for the right patient.
Well, I think it's been some great information. I appreciate you all taking the time tonight. We got a lot of great questions, and a few more have come in, but we're getting past the hour mark here, and I know you all have families to get to. And again, we appreciate the time. And if there are any questions that have not been answered, feel free to reach out to University of Orthopedics. They are open, seeing patients, whether through telemedicine or in person. So please feel free to reach out. We will also post this full video online on YouTube, as well as on University of Orthopedics social media pages. So thank you all. Please stay safe, everyone, and have a great night.
Thanks, Pete.
Thank you.
Thank you.
Thank you.